I realise that I am standing between you and your supper, and that's a very dangerous place for anyone to stand. So my apologies from that straight out. But I really like the title that I've been given here, because I think there's something fundamental about this question, tell or not to tell. You know, to know or not to know. You know, is it good to know? Is it bad to know? Is it good to know early? Is it good to know late? Whether you have dementia. Clearly, nobody in the world would ever want to have dementia or would want their partner to have dementia, because it's a devastating illness that causes all the problems that you all know that it causes. But whether we want it or not really doesn't come into it, because we don't get to choose. And there is nothing that we can do, even no matter how well we run, no matter how far we run, there are still people who run, marathons who end up with dementia. No matter how bright and intelligent you are, there are still people who are bright and intelligent who develop dementia. So we don't get a choice here. What we do get a choice about is what we do about dementia for people with dementia, in terms of public attitudes and understanding, in terms of professional attitudes and understanding, in terms of the services that we provide, which include diagnostic services. But we do need to understand what we can do. And so what I'm going to try and do in the next half hour or so is to explore some of these themes. And then we have plenty of time to talk about those themes and to discuss them and to see what you feel, what you think. So I brought you a present from England. These are clouds, by the way. I know you don't have them. And you can look at that and you can say, is the weather getting better or is the weather getting worse? Is it a bad day or a good day? And depending on how you're feeling, it'll be a bad day or a good day when you look at this. But I want you to look at that and imagine that you're going on a journey, all right? But you don't know where to. And you don't know how long it's going to take. And you don't know what route you're going to take. And you know stuff will happen, but you don't know what stuff is going to happen. And you don't know what to do when particular things happen. And you don't know what form of transport you're going to have to go in. I mean, it could be a hovercraft. How many of you can drive hovercrafts? But you don't get to choose the vehicle that you go in. You don't know the rules of the road. You don't know how to keep safe. You don't know, you've got no choice about this journey. Absolutely no choice whatsoever. And then you find that you're actually already on it, and that you have been from some time. And some of the reasons why things may not have been going very well for the last couple of years is because you've been on this journey already, and you've already made choices, and you've already done things, and they may influence on where you go. And what I want you to think about as we're doing this is, what's the one thing that you need to be able to travel well rather than travel badly? Because it's quite possible that you will travel badly if you do not have this thing. And I'm going to answer that later. It's not that you need a hovercraft to driver's license, I can promise you that. So, where are we? Well, the fundamental problem and I'm going to, sorry, another apology. You may have worked out that I'm from England. My name obviously isn't from England, but I'm from England. And so I know precisely nothing about what happens in Australia, which is actually fine, because you do. You know what happens here in Western Australia, you know what happens in Australia. So the examples that I'm going to give are all derived from my own experience, my own understanding, particularly of the systems in England and in Northern Europe. So I apologise for that. However, what I would suggest, though, is that there are differences, but there are also probably quite a lot of similarities in terms of the challenges. So we know that the problems faced by people with dementia are exactly the same in England as they are in Australia. Some of the solutions will be different, some of the possibilities for change are different, but the illness is the same wherever you go throughout the world. And this is an illness affecting 34 million people at the moment. But one thing we know in the UK is that it's only about 44% of people with dementia who ever know that they have dementia. So to know or not to know, well, most people never know, never receive a specialist healthcare assessment or diagnosis of their dementia. And when they do, it tends to be late in the illness, at a time of crisis often, when people's spouse may die and you realise that there are all sorts of problems there, or someone goes into a general hospital and things are uncovered. But a time of crisis, and when it's too late to enable people to make choices for themselves. And that's partly to do with the lack of capacity, the growing impairments that one gets in decision-making in dementia, but it's also to do with the fact that the time that you could have made that choice has passed. So you've already been through that. Too late, possibly, to prevent harms. So, and to prevent crises. And I suppose what I'm asking is whether or not there is a preventative agenda in dementia, which isn't necessarily about stopping the illness happening. We'd love to be able to do that. And clearly all the things that we do that are to do with what's good for your heart is good for your head. It would be good if I came and went on one of those running things. Well, not in the first instance. It would be rather unpleasant for everyone to look at. And it might, but you get the idea. What's good for your heart is good for your head. We know that. And there are some suggestions that the absolute numbers of people with dementia have gone down by a couple of % because of the good things that we have done in terms of smoking cessation and healthy eating and all of those things. And that's brilliant. But we will never prevent all cases by these simple lifestyle factors, because it's not only determined by that. But there is a preventative agenda in terms of the harms that happen in dementia, the bad things that happen to people with dementia, the bad things that happen to the families of people with dementia, and the bad things that happen potentially to health services and social services and society as a whole. And one of those bad things is the gigantic cost of dementia. So dementia already costs the world $600 billion per year. If dementia were a country, it would be the 18th largest economy. If it were a company, it would be the biggest company by turnover of any illness, in the world. Bigger than Walmart, bigger than ExxonMobil. It's that sort of size of an impact. And it beggars belief that we are spending that money as well as we might spend that money on dementia. So there are harms that one might prevent. But is there a role for knowing early and for knowing what you've got in terms of exercising those abilities to prevent that harm? So here's some data from the UK. We've been tracking the numbers of people who are known to have a diagnosis at any stage of the illness, and it's going up a bit. So in 2011, it was about 41%. Now it's about 44%, and it's great. It's good that it's gone up. But it's not going up very fast. And it'll take us a good few years to change things. And what is the reason for things not changing quickly? Because if I wouldn't be having this discussion with you if we were talking about cancer, would I? Is it good to know that you've got cancer? Well, it's not good to have cancer, but it's good to know, because then you can get treatment, you can do stuff about it. That gives you a chance. But people do ask the question about dementia. And why do they ask the question about dementia? Well, they ask the question about dementia because it is difficult and complicated. We have spent the last 50 years in medicine doing fantastic work with things that are relatively simple. So heart disease, cancer, stroke, diabetes, we are immeasurably better at dealing with those things than we were 50 years ago. You know, we have largely dealt with the problems that killed hundreds of thousands of people in middle life, single illnesses. We've largely dealt with those. And the world changes because of those things. And one of the ways that the world changes is that people live longer. And as people live longer, that is what generates the complexity that comes with old age. And one of the particular things, in terms of complexity, that comes with old age is the likelihood of having dementia. So it is our brilliant success in enabling our populations to live longer that is the reason for the increasing prevalence of dementia, the increasing numbers of people with dementia. This is a symptom of our success, but it also means that the people that we are presented with now have problems that aren't those single, simple ones, but they are the complex, difficult problems that we haven't sorted out yet. And that's what we need to do with dementia, and it's complicated because it's not like an illness that you don't have one day and then a bad thing happens, you get a severe central chest pain, you know you're having a heart attack, you go to the hospital, you get it dealt with. It's quite easy to work it out. But in dementia, we have an insidious onset. You know, it's not one day you are undemented and the next day that you are demented. You've got a gradual process that probably starts some 30 years before you have a single symptom of your dementia in terms of the degeneration of your function in your brain. We've got the fact that there's a lack of insight. You may not know that you have the problem. So this is getting difficult now. How do you deal with an issue where you may not know that you've got it? There is no simple test that will enable you to tell whether someone's got dementia or not. No simple test. If anyone says there's a simple test, they're almost certainly trying to sell you that simple test. And you should be very careful. Buyer beware. And then there's the stigma of dementia, which makes it difficult for people to talk about it. Not only difficult for families affected by dementia, because families are talking about it much more, but actually difficult for professionals who don't feel, able to deal with it. Professionals in primary care, professionals in general hospital, professionals in social care. They have that stigma also, and that leads to inaction and public misconceptions about dementia. The idea that it's an inevitable part of growing old, which it isn't. The idea that there's nothing that can be done for dementia, which is just not true. And we may not be able to make it go away with a magic tablet, but there's loads we can do to enable people to live well with dementia. The fact there's uncertainty about roles. People don't know what to do because we haven't sorted it out yet. And if it's kind of like anybody might be able to do it, then you end up with no one taking responsibility for it, and you can't work out which bit of the system should be doing the diagnosing, for example. That role uncertainty is extremely toxic, and again, it leads to inaction. And that leads to impaired help seeking. It's difficult for people to find help in a system like this. So we're talking about a system that's set up to make it more likely that you will not be diagnosed if you have dementia at any stage of your illness than you will be diagnosed. And that's weird. And that's about help seeking, but it's about help offering as well. So we have a complex system-wide issue here, not just whether a professional makes the right call at a certain time. So why bother trying to change this? There is a problem here in terms of these numbers, but is it worthwhile? What are the benefits of diagnosis of dementia, and what are the harms of diagnosis of dementia? Because it's not a sensible thing to pretend that there's no downside here, because there's a downside to all sorts of knowledge and all sorts of information. But what is the relative amount of downside and upside of knowing, and downside and upside of knowing early rather than knowing late? And you go to the literature to try and find the answers, and you go to that cupboard, and the cupboard is bare, almost entirely bare. There have not been large numbers of randomized controlled trials that tell us the answer to these questions, because those would be very difficult to carry out. Whereas you go to the cupboard for your cancer treatments, for example, and you'll find lots of good quality interventions, information there. So we have uncertainty. We don't know. So what I've tried to do is to bring together some of that information here today to discuss with you. And if we look at goals, and we look at one of the things that has been really positive in the last 10 years, and Australia, I think, was the very first country to do this, is the development of national strategies for dementia, national dementia strategies. And Australia, I think, was the first country to develop that, but there are a lot of countries that have been copying you recently. So the UK created one, Japan has one, the USA has come up with the National Alzheimer's Planning Act. And and one thing that's common to all of them is an injunction that diagnosis should be increased. And that's not about 100% of people being diagnosed, really, is it? Because there are people who don't want to know. And there's no reason why, I can't think of any good reason for forcing people who do not want to know something to know something. It's a very difficult thing to do. And, but again, most people that one speaks to wishes that they had known earlier, and most people that we certainly talked to when developing our national strategies in the UK had said that they had struggled for very many years before being able to get that diagnosis. So it's about 70 or 80% of people with dementia receiving a diagnosis, and when they do, it's early. So going from late and low diagnosis to early and high diagnosis. Early in the illness, early to enable choice, to prevent harm, to prevent crises. That's what national strategies tend to suggest is an important and a useful thing for people to do. And here's a joint statement from the British Medical Association and the Department of Health in England, talking about timely diagnosis. So often, I'm going to use early and timely as a synonymous thing, because the case that I want to make is that what is timely is an early diagnosis rather than a late diagnosis. And what they say is that you've got that the benefits of a timely diagnosis are compelling. Well, one of the problems with that is that the evidence base isn't compelling one way or the other, because the sorts of definitive trials haven't been done. That diagnosis is not an end in itself, but a gateway to making informed personal life choices, and that's absolutely right. So the diagnosis in and of itself is a piece of information. It's then what you do with that information that matters. How that affects you in a positive or a negative way, and how it affects how you are from then onwards through the rest of your journey with this illness. And of course, it talks about the need to provide a full range of treatment options and appropriate post-diagnostic support services. And the problem with this is that they generally don't exist. I'm not sure about whether they exist in Western Australia, but they certainly don't exist in the places where I work, first in South London and then on the south coast of England. So the Council of Perfection would say, well, it'd be all well and good to have this, this early diagnosis stuff, but we'll have to wait until we provide all the services that someone might potentially need before we do it. And is there a problem with that? Well, the problem with that is that we may be waiting rather a long time before we have those services. And there's supply and demand, and if people don't know they've got something, then they don't know they need it. We know that things grow for reasons that are to do with the stimulation of demand as well as the stimulation of supply. So people say bad things can happen when you have the diagnosis of dementia. And here's a case that's often cited. So Gunter Sachs, who was an iconic playboy of the go-go 1960s, according to the American Broadcasting Corporation there. He was Brigitte Bardot's husband. He was that trendy. I think he was a famous downhill skier who became a billionaire and all sorts of stuff. He really is, a remarkable chap. And he killed himself. And he killed himself in his chalet in Gstaad at 78, leaving a suicide note that revealed his struggle with an illness he dubbed A, thought to stand for Alzheimer's. Now, this is a bad thing that happened to this remarkable individual. Suicide is an awful thing for the people themselves and for the families that are left behind. And there is no doubt that some people, have a negative reaction to knowing that they have Alzheimer's. Some people develop serious depressions in Alzheimer's. People commit suicide for a lot of different reasons. But this case has been used to suggest that we shouldn't diagnose people early because bad things might happen. And there's some truth in that. How many of these cases are there? How much harm is there? And what's balancing that? We know that people with dementia have actually got a lower suicide rate probably than people without dementia, but that's probably to do with the choices that one can make when one has dementia. We know that people with dementia develop depression, and we know that older people in general are a high-risk group for suicide and for depressive disorders. So we don't know what the process is here, but we have a hard case here, a hard and difficult case. And there's that saying in law that hard cases make bad law. Do they make bad health policy as well? And it is remarkable that there are people that have, this is a paper from the Too Much Medicine series in the BMJ. This is a kind of, it's an area where they attack things that they feel are going a bit too fast or being driven by drug companies or are in some ways not right. And there are, I think, Australian people here who are part of this authorship. And this paper basically says that the evidence base for early diagnosis is weak. What it doesn't say is that the evidence base for late diagnosis is also weak, though it does cite things like that German, these unfortunate, terrible occurrences that happen in order to support it. But the thing that I want to draw your attention to here is this title here. I'm not sure if you can see it. It says, "The Curse of a Diagnosis." This is incredibly strong language. It's incredibly pejorative language. And, I don't quite understand why it's okay to use this sort of language in dementia. Because if you look at the text, it doesn't give any good reason for this being thought of as a course. But what you have if you start reading this, literature that is essentially against diagnosis, and I've read quite a lot of it now, is that you find that people are fighting battles over dementia that are about other things. That it's not really about dementia. It might be about the drug industry, and it might be about how randomized controlled trials done. It might be concerns about resources. The fact is that if you're sitting in primary care and you have a certain amount of resource, and then you're asked to do another bit of work, how do you do that? You're concerned that there isn't enough resource to be able to do it. What do I stop doing in order to do this new thing? If people feel that they're absolutely at the end of their tether, and many people in primary care in the UK say that. There are concerns about the evidence base, but it's a two-sided lack of evidence. And one of the things about designing, developing, delivering health services and social services is that often one needs to act in uncertainty, to act with and to make decisions with imperfect intelligence. And we are very much in a situation of imperfect intelligence here, as economists would put it. We don't know necessarily what the detail is of the outcomes that will happen if we do something, if we don't do something. We have perfect intelligence often in particular new exciting things that we might do in a particular cancer. But the benefit may be relatively small in terms of numbers or in terms of its impact. What we have here is a low level of intelligence about something where the impact may be very high. So how do we decide? How do we act in uncertainty? Concerns about the lack of services available. We rehearsed this a little. It's, that you can't develop a service that might unmask a need without you being able to meet that need as well. Concerns about national goals and initiatives, the idea because you have generated national strategies, that is in some way the centre talking to the service as a whole, talking to the localities about what they should do, kind of making, if there's been a discussion in many countries which is about freeing up local services to make their own decisions, and then you have the centre telling people what to do. And that can feel very uncomfortable as well. But none of these is anything to do with dementia. It's to do with other stuff. And people seem to be willing and seem to be fighting these other battles over dementia. And I think it's important to understand that these criticisms may, well, not be specific to dementia, but be about a lot of other things, particularly if people feel that the focus is going from one subject which has been focused on for the last 20 years, which people really, really want to do, and then it moves somewhere else. So what does good diagnosis look like? What do we have to do to enable people to live well with dementia? Well, and what does good look like in terms of service? Well, the first bit is likely to be about making the diagnosis well. So let's talk a little about diagnostics. Let's talk a little about this process. Now, I'm not going to take you through how to make a diagnosis of dementia or anything like that. However, what I'd like to do is summarise a few points. Do we have a quick, simple diagnostic test that tells us if we have dementia? Can I take a blood sample, send it to the lab, and they'll send me back the yes? We got that? There's a clue on here, by the way, which is the... There we are. We don't have one of those. And so there is no diagnostic test, nothing that tells us, and it would be great if there was, but we don't have one. And it's actually fairly unlikely as well, by the way, because there are probably 40,000 different gene-environment interactions that lead to Alzheimer's disease alone. So actually, it's a complicated thing rather than a simple thing. If it was a simple thing, we'd have this thing already. So is there a simple and efficient screening test that we could put out in populations that would identify with those people with a high likelihood of dementia? And again, the answer is no. Sorry. Can we make an accurate diagnosis by careful clinical assessment with multidisciplinary synthesis of history, examination, investigation? Yes, we can. But that's a bit of a dull answer, isn't it? It's a bit of a dull answer because it sounds like a bit of a trouble. It sounds like it's going to take quite a while and you're going to have to go to various places. And it's not going to be a simple thing that you can put in a shiny clinic. They can do the magic test. It's not a machine that someone can sell you that will tell you that people have got it. Yeah? And that's the reality of it, unfortunately, because that's where we are with dementia. Are there tests that can help us to make decisions about diagnosis and sub-diagnosis of dementia? Yes, there are. And all of the instruments that that you will have heard about are things that help us to make decisions, that help us to formulate this complicated thing that's making a diagnosis. And it is absolutely true that it is more difficult to make the diagnosis the earlier you go in the dementia. All right? It's quite simple to make the diagnosis if someone's had the illness for 8 years and you've got a very good history and you've been the doctor looking after that person for that 8 years and you've seen the decline and the family can say that it's been slow and gentle. You know, it's quite easy to make the diagnosis because it's probably not something else at that point, but it's more difficult to make it early. But tests can help us. Are there tests that make the diagnosis for us? No. All right, and there's intense activity in terms of research to help us find biomarkers, things that will make the diagnosis for us, things that will enable us to monitor severity and outcome of dementia. But we don't have them at the moment, and we need to be very wary because there's such a hunger out there for information, good quality information on dementia, that there's the tabloid press in the UK, there's the Daily Express and the Daily Mail, and every week they'll have a story about dementia and a new test that shows whether you've got it or not. And you read it and it's about 3 mice in California. And these are papers with, millions, many millions of readers, and they're not stupid people. They respond to the fact that people really want there to be something simple out there. They want there to be an easy way of doing this. And that's as true for politicians as it is for other people. And the G8 summit that happened a while ago was all focused on trying to find these kind of things that will make it all better. And that's really good, because it's really important we do. But it's research at the moment, it's not practice. There's nothing out there that can do this stuff other than, the hard, dull slog of clinical assessment at the moment. And you can do that well, or you can do it badly. So making a diagnosis, it's like making sense of a lot of complex information and often dealing with ambiguity, because, again, it's about making decisions when you don't have perfect information. Dementia gets in the way of people being able to give you perfect information. You have to try really hard. You have to bother to speak to the relative of an individual and to find those old notes that had other things there. And again, that doesn't fit with a model about, quick through. It's, in terms of primary care in the United Kingdom, at least, the average length of time that people have with their primary care doctor is about 7 minutes. You can't do this in 7 minutes. You can't even do it in 14 minutes if you give people a double session, which is one of the suggestions that people have made. So clinical diagnosis. Diagnosis of dementia is a clinical diagnosis. It's gathered by history. It can be opportunistic or planned. It's always better planned. It's very seldom an emergency to make the diagnosis of dementia. There are some things that kind of go for us here, particularly if you're diagnosing things early. It probably doesn't matter if you make the diagnosis this month or next month or the month after. What's really important is that when you tell someone that they've got it, they've really got it. Because that's really important. This becomes a vastly important event, and it needs to be treated as such. So it's not the sort of thing, and again, we've heard about this in the UK, it's not the sort of thing that is best communicated by sending a letter to an individual saying, thank you very much for coming to my clinic. We did some tests, they were all negative. We believe that you have Alzheimer's disease. There's nothing you can do. We'll see you again in a year. Now, that may just be the NHS in the UK doing that. But it's not the best start to that journey, is it? If you think about our clouds that I brought from England for us, not the best start to the journey. We can make a diagnosis. If we've got progressive decline, impacting on daily life, excluding medical causes and other things. And I'm explicitly not talking here about mild cognitive impairment, whatever that might be. There are a set of pre-dementia things that are gigantically important for research again, but really aren't important clinically, because it's just an uncertainty. It's not a diagnosis, it's just a kind of group of people that perhaps you need to follow up a bit more carefully to work out when they actually have the illness, when they develop it. But the vast majority of them will not develop that illness. So we're talking about people with diagnosable, demonstrable dementia, but diagnosing it early. Of course, and it's not about making a diagnosis of dementia, because dementia is just a syndrome that has many causes. And you need to know not only that you have dementia, but what subtype of dementia you've got. And there are lots of them, including some rare, tricky ones, as well as the ones that are more common. And you need that sort of information because it's a different journey you may be on. The treatments may be different. What you may need to prepare yourself may be different from those. There may be different things that you can do to help yourself within those things. And of course, part of what that assessment and diagnosis is about finding risks. And one of the things that's, again, true and well attested is that a lot of bad stuff happens to people with dementia and their families. Yeah? And that bad stuff is caused by the problems of the dementia. And so there's a whole set of risks here, which I'm not going to go through, but include the risk of abuse and harm and self-neglect, fire risks, leaving the gas on, all of those sorts of things can be catastrophic problems. Accidents, traffic accidents, being caught up in accidents, falling over, You fall over with dementia, you go to a general hospital, you receive half the level of pain relief than people without dementia. Not because your pain is any lower, but because you express yourself differently. And so you get your pain treated with an antipsychotic drug because your behavior was deemed bad, rather than getting the diamorphine that would make the pain go away and your behavior go away also. All sorts of harms, all sorts of risks. And the good thing is that we know that we can provide services that are able to make those diagnoses well. So here are data from the Croydon Memory Service, which was a service set up to test these ideas in the United Kingdom in the entirely unremarkable South London suburb of Croydon. I can say that it's entirely unremarkable because I worked there for 11 years. And you know what good looks like in a way here, because it works for the whole population. So it has capacity to see all new cases. It works in a way that's complementary with existing services. These are generally services that have to do stuff that isn't being done. And that means adding something into the system. And it's about making the diagnosis well that we've talked about, and communicating the diagnosis well, and then providing the immediate support and care that people need. And then you start getting services that have high acceptability, that people are willing to go to. And that's really important, that people are accepting of services, that the primary care services can use properly. So this is a specialist service that is used by primary care. Essentially, it's like, if you take a cancer analogy, it would be like somebody having a lump in their neck and going to their GP and saying, I have a lump in my neck. It's very unlikely that your GP would put a needle into that lump, put it under a microscope, and tell you whether you've got cancer or not. And if your GP did that, you need to report your GP to the people. You wouldn't expect it, because it's not a reasonable thing to ask the GP to do. But we sort of ask that in dementia, because we ask them to do this really complicated, difficult thing that can take hours, that actually isn't very easy to do. That does and it's not easy to tell someone they've got dementia, let alone to find out that they've got it. So this is a service that does that heavy lifting for primary care, but has high levels of appropriate referrals, that works for people with minority ethnic groups as well as the majority. So we had double the number of people that we would have expected based on the age and gender distribution of people from South Asian and African Caribbean backgrounds. We did that by creating a service that was able to go into temples and churches and break down some of the barriers that exist to referral to traditional mental health services and enable people to come forward and to receive diagnosis. Works for people of all ages, improving quality of life here. One of the problems that we have in dementia is because we're not making it go away, we're not extending people's lives and stopping mortality, it can be very difficult to demonstrate that what you do has value, so it's worth doing. And that's because people's cognition will decrease, because people's activity limitation will increase. People will become more activity limited with time, even with the treatments that we have at the moment. And so that's where the concept of quality of life becomes quite important. And we developed a system to be able to measure quality of life, which is the DEMQual system. There are other systems available. And we used that to assess the service. So what we wanted was the service to improve people's quality of life, and it did, both by self-ratings and by the ratings of carers. It decreased behavioural disorder, but this little diagram here is probably the most important thing. For a service of modest cost, we were able to increase, over a period of 5 years, we were able to increase the percentage of people who were diagnosed early from about 15% to about 70%. So we were able to do it. It's a demonstration of it's a proof of concept here. And there are literally hundreds of different service models that'll be in Australia and in other places that are able to do these things. You use different models for different places, but this shows that it can be done. But you've got to be careful about these data as well, because this isn't a randomized controlled trial. This is simply a description of a service. This improvement in quality of life that we saw here may be the natural history of dementia, that people's quality of life improves in the 6 months from referral to follow-up. If we look more carefully at it, and we look at those people with the worst quality of life, so this is the bottom half of the distribution, you start seeing there's quite big changes at 6 months. So this effect size here, if I can translate it into human, what this means is that this is about twice as effective in terms of improving people's quality